It's my great honor to present our keynote speaker on the subject of telemedicine this morning, Dr. Robert Bourge. His bio, and in fact I would say just sort of a thin slice of a bio, like a thin slice of an apple, is available for you to read in the program. So I won't repeat it verbatim, but simply let me say that most people in the world do really, I think, the best they can do to do a really good job as one person. Many people, and I think all of us here, do a really good job at just cranking out one hardworking person's life work during their life. But there are some people, and they are very rare and very far and few between, who actually manage to do the work and the brilliant work of 3, 4, maybe even 5 people. Dr. Bourge is one of those. He's an innovator in so many different fields, from cardiology to pulmonology to medical records, software-based research in the field of transplant outcomes and clinical research. He's an inventor of very small implantable devices, an inventor of therapeutic pathways, pharmaceutical development pathways and pharmaceuticals. He's a pioneer in the implantation of all of the different brands of ventricular assistance devices and completely artificial hearts. We are really very privileged to have our keynote speaker this morning be Dr. Robert Bourge, and please join me in giving him a warm welcome.
Thanks, Martine. I'm certainly honored to be here, although with my appetite, I don't think I've ever been called a nano seed, maybe a macro spore, but not a nano seed. I'm honored to talk today about something dear to my heart, telemedicine. And I kind of walk you through it and give you some examples of what's being done and hopefully what will be done in the future. I'm going to focus today on cardiovascular disease, which encompasses, if you think about it, the entire body, because we have vascular vessels all throughout the entire body. And so this topic is both dear to my heart and hopefully dear to all of your hearts, because you all have vessels. Just remember that. If you look at telemedicine, it really encompasses 4 primary areas. First, patient access. One problem I have, and one problem throughout the world, is access to medical care. I'm at the University of Alabama in Birmingham. Alabama is a rural state, and I have patients who come from all over the world, quite frankly. My furthest one right now actually flies to see me from Rome twice a year. But I have patients from South America, from all over. Obviously, it's difficult for access in that manner. And indeed, just in Alabama, I have a patient assistance fund just to allow the payment of gasoline for patients to come from all over the Southeast to see us in our specialized clinics at the University of Alabama. Because of that, and because of this access, and over the years I've seen access problems cause significant issues with the ongoing health care, I became interested in this topic over 20 years ago. The good thing about telemedicine is that the patient can be physically remote from a nurse or doctor. But I will say, nothing will replace the patient-physician interaction. Nothing. And these ideas that we can totally do away with that are wrong. Unless we can get a sensor that monitors everything, including the ambience you get from a patient, the discussion with a patient, the one-on-one communication, I don't think it hopefully will ever replace the patient-physician interaction. Telemedicine allows the patient to also be actively engaged in monitoring their own health. We can have a long-distance communication link with some of my implanted devices, which I'll show you in a bit. I actually have a patient up in Alaska who transmits hemodynamic information to me twice a day, and it comes through on my BlackBerry. And I push 2 buttons and give them specific instructions as to what to do with their medications. Can do it with broadband. Maybe in the future GPS will be incorporated in it, but we can also do it with wireless technology. The monitoring methodology goes from the simple verbal or video questionnaires, simply having a patient answer information, tell us how they're doing. It goes into the non-invasive modalities, such as something as simple as a scale. Again, cost is an issue there. I have a separate fund which purchases scales for patients. Very important if you're monitoring advanced heart failure. And also, we have devices which can be non-invasive and controlled by both the patient and our technicians. For example, one of the examples I used often is the idea of a patient checking their glucose. Unfortunately, for the last year, I've been a diabetic and had to stick my finger to check my glucoses intermittently to assure that my diet-controlled diabetes is still diet-controlled. Well, wouldn't it be wonderful, and actually there are companies working on this, the ability to check the glucose continuously or even intermittently with an implanted device so we don't have to stick our fingers, something I actually hate to do. I'm a wuss when it comes to needles. Implanted devices, patient-operated devices, I'll discuss in just a bit, but very important, the patient interaction and feedback. It can be patient-directed per a patient-specific algorithm, and we are working on such algorithms, but it has to be customized for each patient. Look around the room, look at the guy next to you, the woman next to you, we're all different. And medical care is all different. The idea that every patient should get exactly the same dose of medicine or the same medicine is much too simplistic, and more we're seeing that in how we treat patients. We can do this to talk to the patient verbally. We can do it by video, directed by a health professional, doctor or clinician, and it can be automated again by talking to the patient more specifically. If you look at diagnostics, we have such devices now. Patients who have implanted cardioverted defibrillators, there's one here, placed into a patient. It's, if you will, a life insurance policy. In fact, that's what I tell my patients when we implant one. This is a device that you want to have, but you never want to use, just like a life insurance policy. Indeed, it's there to save your life, should it need to save your life, but hopefully 10 years from now you'll tell me that, oh, you know, I put this device in and I never used it. And I'll say, thank God you never used it. Because you'll know when you do use it. You'll feel it. We can get diagnostic information, for example, atrial fibrillation, the total history per day of a time in atrial fibrillation, which we know now many patients have atrial fibrillation. We would never have known it without this type of software. And the time in atrial fibrillation is directly related to outcomes, both in terms of advanced heart failure and, very importantly, in terms of the risk of stroke. We know that patients who have atrial fibrillation, even for short periods of time, are at increased risk of stroke. So we have such devices today. We're using them routinely in the commercial arena. We do, for another example where I've worked very hard in using implanted devices is in heart failure. We know with heart failure, due to a variety of problems, patients have acute events where they become volume overloaded, they get hospitalized. With each event, there's hemodynamic alterations and progressive myocardial injury. And we know that the more often a patient's admitted, they go into a spiral of worsening clinical status. And indeed, if we can interrupt this spiral, and patients do better in the long run, and we've attempted to do this with a variety of devices to help us monitor a patient's congestion. And there's one key element here with heart failure is that congestion that is measured by increased intracardiac end diastolic pressures. So the volume of fluid in the body is associated with worse symptoms and, in the end, worsening survival. So we hope to use these devices to not only control arrhythmias, as the first example I gave you, but to help control congestion. And the idea is that we're only seeing, if you will, the top of the mountain. It's not an iceberg here, it's a beautiful snow-covered mountain. In this case, the mountain's covered with lava. It's a heart failure event. And the symptoms often begin days, sometimes hours before the event. But if we look at what's happening within the patient, what we're doing is we're reacting to that event. We're admitting the patient to the hospital. We're giving them additional toxic drugs. There's only one drug we use in the treatment of heart failure that's not been shown to worsen outcomes. One drug. Most all of them, inotropic drugs, diuretics, they're poisons. Lasix is a great poison. That's how it works. It poisons our kidneys. If you can stay off salt, you don't need as much Lasix, as I tell our patients. Salt is like poison to you. We have to counteract the results of salt by giving you additional poison. We give inotropic drugs. Again, it's a poison. It helps the heart beat stronger, but it worsens survival. So again, we'd like to be able to stop these events so we won't have to use as much poisons, if you will. And what happens, and we've shown this in a study I'm about to show you, we've shown that pressure changes begin as early as 6 weeks before such an event. So if we can detect these pressure changes way before even the patient feels anything, we may be able to influence outcomes, and we can become proactive in the therapy. We can do this. We can measure the pressures, we can do a medical intervention, and we can hopefully stave off that heart failure event. We can do this by maybe simple technology. This is data from the TENS. It's a Trans-European Home Monitoring System study. Treated over 500 patients, randomized to usual care. That was just the patient comes in, has an event, and goes home and sees the doctor intermittently in clinic, versus nurse-directed care, where the nurse is calling and asking how patients are doing, versus a home telemetry monitor, where the blood pressure and the weight is automatically transmitted. And each of these progressively uses also the things before it. So home telemetry will also use nurse-directed therapy. So you add additional levels of support for the patient. This study was recently published, and what it showed was, very importantly, if you count, and this is a little controversial, but if we look at both the days in the hospital, over 240 days of follow-up, or the days not alive. Dr. Cleveland likes to use days dead. I like to use days not alive. It sounds a little more touchy-feely to me. We can see the days in the hospital did not significantly change. Days in the hospital for heart failure did not significantly change. But if you look at days death or days in the hospital, all cause, especially for heart failure, you can see things got improved, that is, the bars got lower with home telemetry monitoring. And indeed, if you look at mortality, just survival, this is distribution function, you can see how things improved out even past 300 days to a significant difference in the patients who were having home telemetry monitoring, significant difference. If you look at structured telephone support, that's not home telemetry, but that's just calling the patients. If you look at all the different studies that have been done, the p-value is not even significant for overall effect, either for relative risk or for overall effect. You can see by the red arrows. If we look at, and these are combined tables from multiple different sources, but you can see if you look at telemonitoring versus on hospitalization, telemonitoring on mortality, we can see on mortality it actually reached statistical significance with a p-value of 0.003. So telemetry monitoring, home-directed telemetry monitoring, even without the implanted devices, helps. Now, can we improve on this? Because this is not an inexpensive therapy. In this study, the average cost per week was almost $300 per week per patient. Medicare, for example, if I see a patient in the heart failure clinic, pays me $39, and it costs me $13 to develop the bill, just the bill to send to the patient. And it costs me $42 for the clinic room. So you can't make it up in volume when you're losing $12 per patient. It's difficult. So, and this will bring up some questions we'll discuss in the end about who's going to pay for this. One thing that I started working on, one device I started working on in 1992, a long time ago, was implantable hemodynamic monitor, where we could place a catheter and a lead in the patient's, there you go, in the patient's heart and measure right ventricular pressures continuously. This device also measures heart rate, it measures arrhythmias, temperature, barometric pressure, measures a whole bunch of wonderful things. And we've now completed one study with this device. It measures right ventricular diastolic pressure, which is an index of filling pressure on the right side of the heart. It measures right ventricular systolic pressure, and it measures estimated pulmonary diastolic pressure. This is an index, EPAD, estimated pulmonary diastolic pressure, is an index of left-sided congestion. They can be they're both interdependent and independent. They do reflect each other, but therapy of left-sided filling versus right-sided filling is quite different, especially in patients with pulmonary arterial hypertension. We did complete one large randomized study, which we published in JACC in 2008. But in patients who were class 3, as you can see, we were underpowered. The p-value event rate difference in hospitalization was only 0.058. Based on this, unfortunately, it wasn't quite good enough for FDA approval. So other studies are ongoing. If we look at time to hospitalization, the event we're trying to prevent again, we see in those patients where we had the chronic implanted versus the control, a significant difference in time to hospitalization. Now, and just like with home telemetry monitoring, we added this device, therapy, directed therapy, in a blinded fashion to nurse-directed therapy, where patients are being called an average of every 5 days to see how they're doing. They're doing daily weights, they're doing scales, but on top of that, we're able to reduce the time to hospitalization. We can also, in pulmonary hypertension, we found that we can actually calculate cardiac output. I won't go through the specifics of this, but using both pulmonary artery pressure and right ventricular pressure, we can actually calculate cardiac index, which is very important in the therapy of patients with pulmonary hypertension with an excellent R value. You can see the line of identity here, estimated versus measured cardiac output by implanted other devices done by catheterization. Now, do we need a big device? Well, no. We're also testing this device, about smaller than a grain of rice. As you can see, it's the CardioMEMS wireless heart failure sensor. It's placed in the aorta here. We can also measure aortic pressure, and we can measure pressure in the pulmonary artery. This little device is shoved out the end of a catheter, which we pass into the heart. Takes about 4 minutes to install. Pass the catheter out into the pulmonary artery. You have another little wire that shoves it out the end of that balloon catheter, and it pops open and sits there. Doesn't have a battery. It's activated from an external wand, which transmits energy to it. It activates, and it gives me a very high resolution signal in terms of what's going on in the heart. This is an example of me using that information in a patient who I placed the device in August of 2007, and this is through March 10th of 2009. She didn't listen to me at first, and then she got admitted, and I started having her transmit twice a day. This is a doctor's wife who did not like following my instruction regarding salt. So I became very intense with her. Big Brother Bob was watching, and only by getting her to cut down her salt, by me calling her twice a day. Look at her pressures. This is very high. 50/28. Prior to the implantation of this device, in the year prior, she had 17 admissions for heart failure exacerbations. I started this program here in October of 2007. Since that time, she has not been admitted to this day. In fact, I got her pressures in this morning. They were perfect. She listens to Big Brother Bob now, and look at her pressures. They came down to normal, and they've consistently been normal, other than when she went on a cruise once and ate some salty food. In the Champion study, we're studying this device in 500 patients in a randomized trial. There are other devices being experimented, including edible electronic monitors, these little chips, like smaller than a pill. You swallow the pill, the patch goes in the front of your body, and it transmits information to the patch, which transmits it wirelessly through the internet, tracking heart rate, respiratory rate, temperature, and activity levels in people. These are certainly experimental, but things are coming. Ideally, we'll have a complete system such as this, where the patient at home has a video monitor, he has a wireless connection to a scale, blood pressure cuff, EKG. Patient, if needed, the more sick patient has an implanted monitors for arrhythmia, hemodynamics, and even labs such as glucose. The patient, this information is connected by broadband to a personal health care clinical application, which involves nurse, doctor, care manager, the hospital, the pharmacy, all these things interrelated, so we can actually provide the drugs directly to the pharmacy. The patient has a remote control. They click a button. The TV comes up, talks to them, charts their information, directs their medication, and gives them specific information, as you discussed with me yesterday. We're already working on this. Very interesting. The development will improve, of the future devices will involve improved sensor and communications, evidence-based therapies, clinician-led models of service. These pathways need to be developed, and we're working on that, and they also need, very importantly, to be patient-specific. And very importantly, what is going to be the proper business and healthcare economic model? Indeed, as we look at this, I have some physicians that will actually tell me Well, Bob, I don't send a lot of my patients to you because once I do, they don't get hospitalized anymore. And I get paid if they get hospitalized. I hear that very often, believe it or not. So in summary, I'd like to thank everyone for coming. This is, as you all know, our third meeting of this sort. I'd like to thank Dr. Bromberg, who's a wonderful role model for me and an excellent leader of this meeting. I'd like to thank the original group. This is us when it wasn't snowing quite as bad back in 2008. And very importantly, I'd like to thank Martine Rothblatt, my good friend and my sister, for having me come here and have some coffee with her. Thank you very much.
Those are great photos, Bob, and a fantastic survey of the field of telemanagement. Definite evidence you presented to us there about improved therapeutic outcomes from telemanagement. Let me open the floor to any questions for Dr. Bourge.
Yes, Todd.
So one of the interesting challenges when you have a lot of these implanted devices, you're suddenly getting a huge amount of data from people that we didn't have before. How do you go about distinguishing in that case what's normal if you're not getting the same kind of data from healthy people?
Very good question. In fact, what's normal to one patient is different to another. Indeed, we have suggested normal ranges for all of these devices. With the Chronicle device, for example, we used it in a non-randomized fashion in over 100 patients for 4 years to determine what we thought was normal, because we never had this data before. We didn't know what was normal. We developed what we thought was normal variables, but it depends on the patient. For example, a patient who has diastolic dysfunction, a very stiff heart, needs a higher pressure than a patient who has systolic dysfunction, a higher intracardiac pressure. If you suddenly try to lower the pressures too much, the patient will often pass out or develop renal failure. So it depends on the underlying diagnosis, and that's why pathways are very, very critical in the application of this data. Computerized analysis of the data is also very important. What I didn't show is a computerized algorithm which we developed, which is almost, but not quite as good as someone experienced, like me, looking at the pressures and detecting when the physician or the clinician needs to look at the pressures. I have right now 42 people with these devices, and I set ranges for each of them, and I receive an email twice a day if they exceed or go below those ranges. Most doctors are not going to do that. I guarantee you. One thing, they're not going to get paid for it, and two, they haven't bought into this as of yet. In other words, how many hours a day do you spend looking at this information and discerning from it? Also, most doctors don't have the infrastructure, the research infrastructure that I have to assist me. I have the patient's information. I could call them, but what I do is I push 2 different buttons, and I have a set algorithm of what to tell my clinical nurse, who gets an email back on her phone, and then she calls the patient. Saves me time. It works all over the world, too. Yes, sir. Come up to the mic.
Please feel free to announce your name when you come to the mic, so all the nano apples, which are going to, orchards of nano apples, which are going to grow from these nano seeds, know from whence they came.
Well, I'm Stephen Lee. I'm from Ohio State University, and your comments suggest that there's a political dimension or a sociological dimension to this,
Definitely.
which has to do with the mechanisms by which we pay physicians. And so what you're talking about is instituting a care model that fails to pay the piper for many of these guys. And so that's probably going to be a tough sell.
It will be.
So would you comment about what sort of changes need to occur before this can be successfully implemented?
Well, unfortunately, physicians are adept at skirting around rules in terms of what they can get paid for. I just saw a report by the AMA. They were actually bragging that 60% of doctors in the United States give away free care. 60% of them. Only 60%? I mean, what the hell is this? Why would you brag about that? It's crazy. That being said, for this model, I see a reimbursement rate based on a monthly, if you will, payment for doing the review, which is higher after either an event or the implant, and then becomes progressively less as you hopefully make a patient get within a certain range, with bonuses for a patient doing well. Because one problem we had with the COMPASS trial was that despite my best efforts at 29 centers, 12 of the centers put the devices in and never did anything. They got the information but never acted on it, even though one of the check marks was, I have followed the care guidelines. That was just a check mark, whether they did or not. For example, at my institution, in the control group, the event rate per 6 months was predicted to be 1.8. Just in the control group, it was 0.9 hospitalizations per patient, because we follow our patients very carefully. In the active group, where we're looking at the information, it was 0.2. So 0.9 to 0.2 is statistically significant just in my 29 patients. In over half the groups, there was no change between active or not. And if you look at what they did, yeah, they had the information, but they didn't do anything. So again, this is giving us diagnostic information. It's not treating the patient.
So Bill Dinan, Medical College of Georgia. So our
And many of these institutions were in these studies with me, by the way.
That's great. I hope we were, but I don't know who at our institution would have been. We do serve a population that's perhaps similar. It's rural. It's underserved. A lot of burden of chronic disease. And there's a group of people in our healthcare system and in our school that have followed what seems to be a different path, which is establishing a center for patient and family-centered care, sort of with the hypothesis that drawing the families in improves outcomes, which it does. And I'm wondering if there's a way that one could meld this very intensive high-tech approach, which, as we've heard, suffers from the not being enough physicians in the whole world to really monitor and use this data, with the idea that you could make it more self-sustaining by having the patients or a family member be able to do a lot of this follow-up, a lot of looking at the data.
Indeed, that is the model we used in the studies I described. We start simple. I see these implanted devices being used on a small minority of patients who have the disease, less than 10%. The very ill ones need such monitors. The companies would like to put it in everybody, obviously, because they cost about $15,000, $20,000, but only a small proportion need it. And indeed, if you get the family in, you give education, and you assure compliance, that's the key. Even with this, having the information that the patient's not going to do what you ask them to do, for whatever reason, outcomes are going to be poor. In fact, non-compliance, either with diet or medication or other things, is the #1 reason for hospitalization in cardiovascular disease. People just don't listen despite our best efforts. And quite frankly, our current fee-for-service environment in the United States doesn't promote that. The more you see them, the more you get.
Bob, could I make a comment? You're pointing out that each patient is different and requires different care. One of the great advances would be to be able to identify by their genetic differences those who are likely to have trouble and those who are not. And of course, much of the recent work using SNPs and polymorphisms to detect those at higher risk. Another point I couldn't help making is that many of the devices that you've built on and applied were developed by NASA for the space programs, for the Mercury and the Apollo, when they had to have constant monitoring of cardiovascular phenomenon and others going when they were going around the world, and then later when they went to the moon. And that was the basis of the ICUs and the monitoring devices, and also the invention of the MEMS, microelectromechanical systems, was done on contract to place some MEMS on a rat's heart valve for measurements in space, and then for the chromatograph they put on Mars. Some of the study centers you used were in places that have, in effect, government medicine, socialized medicine. in those systems, at least I think in theory, the doctors actually get paid more if the patient doesn't get sick. Well, were you able to make any measurements?
Unfortunately not. Even in the government systems, as you say, there are very few who actually get paid more in the United States if the patient stays well. Very few. It's in our centers 29, there was only one. So it's hard to make an analysis on that one center, and they only put in 6 patients, so I couldn't do a separate analysis.
Presumably that would make a difference, wouldn't it?
Maybe.
All right. One last question, yes?
I have two comments. Chezi Barnold, Hebrew University of Jerusalem. One is related to actually all the political aspect, whatever social, what you said. I think it's more money than everything else. I think it's a problem that I know for a very long time, developing a drug delivery system that actually you may lose much less drugs, that, for example, the companies really shut the doors. They don't want to hear about it, you know. So I think these problems is something that really may destroy the medicine from being much more beneficial to people. And I think we as scientists, MDs and social workers have to find solution to this. The second is really something related to the telemedicine that you said. We have an experiment ongoing in Israel, in Jerusalem, in our hospital, that is used by orthopedics department, in which patients that agree are attached to a GPS. And this changed the world of the orthopedics, because once the patient released home, they have a continuous monitoring on the state of the patient, how much you walk, how fast you walk, where you go. After every surgery, you have now an objective information about the status of the patient, because what happened many times, patients come to the physician, depend on their nature, I don't know what, they said, I felt terrible, I couldn't do anything, I just lie in bed, but then the physician looked at the record and said, guy, here you walk 2 kilometers this day, 4 kilometers the other way, so don't tell me story. Or the opposite, people that are always optimistic and for some reason they say, we feel excellent, but the physician now saw the guy, actually the physician or the nurse, it's a very similar system to yours, can call him and say, you have to walk now 3 times a day, that and that, and they can see how many times he went to the bathroom, everything. So I think it really, the people like it. It's a software that developed in our university and now started actually interesting from geography department, where tourist offices in different countries want to see how tourists are doing. And later it was transferred into hospitals, and now it transferred to many other things. I think it's a very, very powerful technique. The device is very cheap. A GPS also has a phone that the physician or the nurse actually see when the battery are running out. They call the patient and say, you have to load your batteries and things like that. So system work perfect. And I think it really will change the world of medicine.
We're trying. My wife makes me wear this so she always knows where I am. My little GPS. Hi, Tess. That's my wife in the back.
Thank you very much, Dr. Bourge. Well, that's both Dr. Bourge's presentation and the questions are a great lead-in for the tremendous potential that telemanagement of very small devices have.